In learning about the heart, you might think, okay, respiratory is breathing, we need to know about the lungs, why are we focusing on the heart? Well, the heart and lungs are so interconnected that when there's problems with the heart, it affects breathing and it affects the lungs. Typically, what we have is pulmonary edema, where when the heart is not contracting well enough, then blood tends to back up into the lungs, into the interstitial spaces that we talked about, and now the patient is short of breath. So that's why it's connected, and you have to learn about the heart. The other thing is, working in the hospital, you're working in critical care, and the heart surgery unit, there's always a respiratory therapist there, and a patient has, they call it open heart surgery, but it's not like they're always opening the heart unless they're putting a valve in. But they still say open heart. It's really open chest surgery. And they'll bypass the vessels in the heart. But when the patient comes to the ICU, they're kept sedated. And then the respiratory therapist has to put them on the ventilator and then monitor them until they wake up from anesthesia. Everything is hemodynamically stable. Then you wean them off the ventilator. So when you're getting a report about valves being replaced, about certain vessels being replaced, they'll say there was a blockage in the LAD. Well, unless you've had your anatomy and understand how important that blockage is, then it wouldn't mean anything to you. So that's why we give you this background anatomy and physiology. So we'll start with, where is the heart? Turn the lights off. Does everybody have a handout? So it tells you that the heart is located in the mediastinum between the sternum and the vertebrae. Now, when we always say, okay, put your hand over your heart and say the Pledge of Allegiance, we put our hands not on the sternum, we put it over on the left side. Well, 2/3 of the heart is on the left side. The main part, or the base of the heart, is actually behind the sternum. So where all the valves are located is kind of protected by the bones, by the sternum. And then the left ventricle is more over to the left. So in your notes it says 2/3 of the heart are on the left of the sternum. And when we're doing CPR, we put our hands on the sternum and we compress the sternum in order to squeeze the heart and eject blood from the heart when the heart is stopped. You might think, well, shouldn't we be putting our hands over to the left of that? And the answer is no. So when you're placing your hand on the sternum and compressing down, you're compressing part of the heart, since it is in the mediastinum. The other thing is, when you press down on the sternum, you're increasing the intrathoracic pressure in the entire thorax, and that also ejects blood out of the heart. So that's why CPR is effective when you're pressing down on the sternum. So nothing more to write on that. With the apex of the heart, what's interesting is when we think apex, we think the top. You know, when you reach the apex of the mountain, you're reaching the top of the mountain. Well, with the heart, it's different. It's actually the bottom. It comes to not really a point, but it's narrowed. That's considered the apex of the heart. So right down, it's at the 5th intercostal space and the mid-clavicular line. Yes, the apex of the heart is actually the bottom of the heart. It's located at the 5th intercostal space and the mid-clavicular line. And this is a perfect spot to listen to heart sounds. So where would you place your stethoscope? So mid-clavicular line. Would it be on the right side? Would it be on the left side? It's going to be on the left, mid-clavicular, so the middle of the left clavicle. And then the ribs, when you're counting, you know this bump on the sternum, your angle of Lewis, is actually your second rib. So then you could palpate 3, 4, 5, and then go over to mid-clavicular. So right underneath breast tissue in women is the mid-clavicular line, 5th intercostal space. So that's where you hear heart sounds the best. And then the base of the heart is below the second rib. It's below the second rib. And the mid-sternal line. So below the second rib and the mid-sternal line. All right, so where is mid-sternal?
Middle of your sternum.
Middle sternum. Second rib, you feel the notch. So imagine like right behind that is where the base of the heart is. Now it's the top, of course, it's not the bottom. The base of the heart is where all the valves are located, where you have your aorta leaving the heart, the pulmonary artery leaving the heart. And the picture shows it. So this is considered the base. And then you have your aorta, pulmonary arteries, and veins. The next slide talks about the sac that surrounds the heart. It says to name the sac surrounding the heart, and what you have to write in there is the pericardial sac. It's the pericardial sac is the name of the sac surrounding the heart. Oh, it's listed on the picture, isn't it? So the sac surrounding the heart is called the pericardial sac. And it's interesting because the pericardial sac is just like the pleural space in the lungs, where there's a real thin membrane of tissue covering the heart. But then there's a second layer, and that's the pericardial layer. And in between that is some serous fluid. So it's a potential space where a lot of fluid could accumulate. And that can happen with trauma where blood from the heart leaks into that pericardial space and gets trapped in there. And it starts surrounding the heart and building up. And now it's compressing the heart. So it becomes an emergency when something like that happens. And when you're reading in your textbook, they have clinical focus. And it's usually a big square, and it goes into detail and talk about a clinical situation. I highly recommend that you read those. There's one talking about cardiac tamponade, where the pericardial sac fills with a lot of fluid and what happened to this patient. So make sure you read those to get a better understanding of what a pericardial effusion can do. Don't think, oh, it's so big, I'm just going to skip that and read the words. Yeah, make sure you go into those clinical focus and the concept questions too. So you have the visceral pericardium and the parietal pericardium, just like we had visceral and parietal when we talked about the pleural cavity. So same thing with the heart. So visceral pericardium and parietal pericardium forms that pericardial sac. So then it says, fluid buildup, pericardial effusion. So pericardial effusion is when fluid accumulates in the pericardial sac. Fluid accumulates in the pericardial sac. Did you get that? And this picture does it justice. You need it again? Fluid accumulates in the pericardial sac.
That's our fluid effusion, or pericardial effusion.
Yes. So you can see how there's this white area surrounding the heart is a collection of fluid. So that squeezes the heart and prevents the heart from ejecting its normal amount of blood. So for cardiac tamponade, what you could write is the amount of blood ejected from the heart is decreased. The amount of blood ejected from the heart is decreased. the amount of blood ejected from the heart is decreased. So if that's the case, what do you think would happen to somebody's blood pressure if they have cardiac tamponade?
It drops.
It would drop. So if there's something squeezing the heart, it can't fill as well. And then when it contracts, there's not as much blood to push out. So the cardiac tamponade is going to be decreased blood pressure. Question?
You said the two rings that made up the pericardial sac was visceral and
Parietal.
Parietal.
P-A-R-I-E-T-A-L. Does it have it on this slide? Let's see, it says pericardial space. It says parietal layer here. Does it say visceral anywhere?
On the top.
On the top. So the visceral layer, the parietal layer, and in between, it's called the pericardial space. But is there really a space there? No. It's just filled with a little bit of fluid. Okay, so the other layers of the heart muscle, or the heart wall, you have the lining that's getting exposed to blood all the time. Blood is passing through it. And the innermost layer is endo. I think endo, to help me remember. So endocardium. And then the muscle layer is called the myocardium. And then the layer surrounding the myocardium is called the epicardium. So what do I have? I just have outside layer. Epicardium, outside layer. The myocardium, I have muscular portion. And the endocardium, I have endothelial tissue.
Can you say that again, please?
Epicardium is outside layer. Myocardium is the muscular portion or muscular layer. Endocardium, endothelial tissue.
Endothelia?
All right, so I have a question for you. What is myocardial tissue death called? So if this muscle layer dies, what is that called?
Necrosis?
Necrosis, yes, it is called necrosis, so dead tissue is necrosis. But when it happens to the heart,
Myocardial infarction.
yes, myocardial infarction. So necrosis means dead tissue, infarcted tissue is also dead tissue. So myocardial infarction would be dead muscle tissue in the heart. Now we're going to go through the chambers of the heart. This is a review for you because we had this in your introductory class. The atria accept blood coming from different places. So the atria are considered the collecting chambers. It tells you that the right atrium collects deoxygenated blood, which is returned from the body through the superior vena cava and the inferior vena cava. Superior vena cava, what does that drain?
The head and the upper extremities.
Yes. So head, upper extremities drains from the superior vena cava. And what about inferior vena cava? Yeah, the rest of the body goes into the inferior vena cava and then that comes back to the heart. So we'll talk about the ventricles separately. The left atrium collects oxygenated blood, which is returned from the lungs through the pulmonary veins. So left atrium is receiving blood that came from the lungs. So once the blood went to the lungs, it picked up oxygen, got rid of this carbon dioxide. Now it comes back to the left atrium. And the ventricles are called the pumping chambers. So the atria were the collecting chambers. For this one, you write down pumping chambers. The ventricles are the pumping chambers. So when the right ventricle contracts, it's pumping blood into the pulmonary arteries. And of course, the pulmonary arteries travel all the way to the alveoli. And that way blood can receive oxygen and give up carbon dioxide. And then the left ventricle pumps blood out through the aorta to all areas of the body. So the right ventricle is pumping into the pulmonary artery, and the left ventricle into the aorta. Write this down. Compare the thickness of the left ventricle myocardial layer to the thickness of the right ventricle myocardial layer. So we're comparing the thickness of the left ventricle myocardial layer to the right ventricle myocardial layer. Let me just review the chambers and then we'll talk about the thickness. So we have the atria receiving blood, and we have the ventricles pumping blood. This is the right ventricle, and it's pumping blood into the pulmonary artery. And the pulmonary circulation, we're going to have a lecture on it in 2 weeks. And what I tell you about that is that it's a real low resistance circuit. So it's real easy for the right ventricle to pump blood into the pulmonary system. Not a lot of work needs to be done. The left ventricle has to pump blood to the entire rest of the body, and it has to pump against more resistance. So just like when you're working out, if you give your muscles more resistance, what happens to your muscles? They increase in mass, don't they? All right, so which mass do you think is greater? The right ventricle or the left? Yes. So the left ventricle has a larger muscle mass because it's pumping against a greater resistance. Now we're going to talk about the valves in the heart. The tricuspid valve is located between the right atrium and the right ventricle. I think you're used to referring to it as the AV valves, the atrioventricular valves, between the atrium and the ventricle, so atrioventricular valves. So that's the tricuspid valve. The tricuspid valve opens when the ventricle relaxes. It closes when the ventricle begins to contract. Just a couple names to write down. When the ventricle relaxes, that's referred to as diastole, D-I-A-S-T-O-L-E, diastole. So when the ventricle relaxes, that's considered diastole. When the ventricle contracts, that's called systole. Next, the pulmonic valve is located between the right ventricle and the pulmonary artery. And I think you guys like to call it the semilunar valve. This opens when the ventricle contracts, but it closes when pressure in the pulmonary artery exceeds pressure in the ventricle. Let's look at a picture. All right, so looking at the valves, the tricuspid valve, imagine that this ventricle is full of blood. And when it's full of blood, it's going to push this valve closed. So the filling with the blood, and then when it contracts, it just shuts the valve. Same thing with the mitral valve on the left. Left ventricle, when it fills with blood, it's pushing this valve closed. And then when the ventricle contracts, it closes the rest of the way. So it just gets pushed closed. And we talked about aortic and pulmonary. Now the valve going into the pulmonary artery, when the heart contracts, it pushes the valve open. So what do you think causes it to close? If it's pushed open, why is it going to close?
Back pressure.
Excellent, yes. So when there's a lot of blood in the pulmonary artery, it's going to push the valve shut. Same thing with the aortic valve. When there's a lot of blood pushed into the aorta, it pushes back on the valve and shuts the valve. The mitral valve is located between the left atrium and the left ventricle. I feel like I'm reading it twice. And I just explained it. It opens when the ventricle relaxes, and it closes when pressure in the left ventricle exceeds the pressure in the left atrium. The aortic valve is located between the left ventricle and the aorta. It opens when the left ventricle contracts. It closes when pressure in the aorta is higher than the pressure in the ventricle. And then do you remember this picture that I showed you? You had to figure out, okay, now these valves are closed, these valves are open. Which one is diastole? So here you have the aortic valve is closed, the pulmonary valve is closed, but the AV valves are open.
Diastole.
That's diastole. How can you tell? So these valves are open, so the ventricles can fill with blood. And we know the ventricles fill with blood during diastole. So that leaves systole on here. But if you didn't know what was left and you had to guess this one, you would see that the pulmonary valve is open, the aortic valve is open. And at what point in the cardiac cycle do the valves open? During systole. So the ventricles contract, and that pushes the valves open, and that's when the blood leaves the heart. It also pushes these AV valves closed. What creates heart sounds? Is it the valves closing or the valves opening? It's closing. What creates heart sounds? So when we listen to the heart, what are we listening to? We're hearing the valves. Do we hear the valves open or do we hear the valves close? And the answer is we hear the valves close. So there's two sounds that we hear, and it sounds like love and duck. So love is also known as S1, and that's when the AV valves close. Duck?
Did you say love?
Yeah. Love. L-U-B, like love,
Okay.
love. Love is S1 sounds. Those are the AV valves closing. That's the first sound you hear. It's when the AV valves close. And then you hear the sound dup, D-U-P. Those are S2 sounds. And that's when the aortic and semilunar valves close. Or aortic and pulmonary valves. I said semilunar. So aortic and pulmonary valves close. That's the second sound. Another picture showing the same thing. Can you tell which one is systole? Because the cardiac muscle is being squeezed. And then you look and you see which valves are open. Tells you that valves prevent blood from flowing backward. If blood flows backward, that's called regurgitation. What are chordae tendini? These are ligaments attached to the AV valves. And I will show you a picture of chordae tendini. Those are ligaments attached to the AV valves. So look at the AV valves. Do you see these stringy things? Those are called chordae tendini. Do you remember the names of the muscles from your anatomy and physiology class? Because there's like these little muscles that attach to the tendons. Wow, that's really good. A trivial pursuit there. Yeah, so it's the papillary muscles and then the tendons attached to them. No, it's not a test. All right, more questions. What is mitral valve regurgitation? Can you tell by the name what's happening? The blood is flowing backward through the mitral valve. So I have written backflow of blood into the left atrium from the left ventricle. Do you want to write it that way, or you can put it in your own words? Backflow of blood into the left atrium from the left ventricle. Sometimes people can be born with the mitral valve not functioning well, or it can develop from an illness or disease where the mitral valve is no longer closing correctly. So imagine when the ventricle contracts to push blood into the aorta, instead blood is leaking backwards up into the left atrium. So that, depending on how bad it is, it could really compromise blood flow to the rest of the body. So if it is severe enough, then it needs to be treated soon. But if it's not that bad, usually people just live with it. And then last question, what is mitral valve stenosis? And stenosis means narrowing. So narrowing of the mitral valve. So if the mitral valve is narrowed, what kind of a problem do you think that would create? Right, so the blood is in the left atrium, it needs to get into the left ventricle, but not as much gets in there because of that narrowed area in the valve. If you ever have strep throat, make sure If you have a sore throat that lasts more than a couple days and it's really severe, there's a good chance that it's a strep throat, where the streptococcus bacteria is growing in the back of your throat. And once it gets into your bloodstream, it loves to sit on heart valves. And within 2 weeks of having that infection, it can cause mitral valve stenosis. There was a 40-year-old female at Broward Health who were doing rounds with the pulmonologist. You guys will be doing that during your second year, where you're given an assignment, you go to the hospital early in the morning, and you do a workup on a patient, and then you present it to the pulmonologist. So usually around 10 o'clock in the morning, the pulmonologist gets there, and we have bedside rounds. So you report off to the pulmonologist. So anyway, that's up and coming, but there was a 40-year-old who had a history of a really bad sore throat. She didn't want to go to the doctor. 2 weeks later, she was really short of breath. Sure enough, when she comes to the ER, she had to have emergency surgery because her mitral valve was just shot from the bacteria sitting on the valve and eating the valve. So, mitral valve stenosis is narrowing of the mitral valve. All right, quiz time. Name the 2 AV valves. It's the one on the right. Very good. So mitral and tricuspid. Which one's on the right? Tricuspid. And I remember T-R-I. R-I is like right. So tricuspid is on the right. And the mitral is on the left. Name the 2 semilunar valves. Yes, pulmonary and aortic. Which one comes after the left ventricle? Aortic. Which one comes after the right ventricle? Pulmonary. Okay. Of the 4 valves, which one has only 2 cusps? Mitral. Very good, mitral valve.
Can you call it bicuspid or no?
And when you're working in the heart unit, they never say the bicuspid. They'll say mitral valve. With the AV valves, they'll never say the bicuspid valves or the semilunar valves anymore. So, I know you learned that in your anatomy class.
Yeah.
Trace the flow of blood from the inferior vena cava through the heart. Mention the name of each valve you pass. Somebody like to do that?
What do you want us to do? Name the valves?
The flow of blood. So you're in the inferior vena cava. Where do you go?
Right atrium.
Into the right atrium.
Then the tricuspid valve. Into the right ventricle.
Okay.
Into the pulmonary valve.
Okay.
Into the pulmonary arteries.
Okay.
Up to the lungs. Circulation, the pulmonary circulation.
Okay. Okay, and then the pulmonary veins.
Then the left atrium.
Into the left atrium. Through the mitral valve. Left ventricle. Aortic valve. Into the aorta. Good job. Can you do that for the test?
Yes, you can.
All right, then we have the coronary arteries. And the coronary arteries, is it? No, what it doesn't tell you is where the coronary arteries originate from. And they originate from the aorta. They're the first, what is that?
Somebody coughed really weird.
You guys are easily amused. So the coronary vessels branch off of the aorta, and they're actually the first branching off the aorta. So if you were ever asked, what are the first vessels to branch off of the aorta, usually you think of the arch of the aorta when you've got your subclavian artery, but that's not the first one. The first one is actually the coronary arteries. And then there's two. There's a left coronary artery that branches off and a right coronary artery.
So the coronary artery is the first one to branch off?
Yes, the left and there's a left coronary artery that branches off, and then the right coronary artery branches off. So there's actually one, two. And you can't really tell when you're looking at pictures. You can't really see the coronary arteries branching off of the aorta because they're kind of hidden.
They're in the back of the heart.
The coronary arteries are in the back of the heart, or where they branch from the aorta. They branch. No.
Isn't it where it says OCA?
Yes. So there's the right coronary artery and the left coronary artery, so they kind of branch opposite each other. All right. The left coronary artery has two main branches. It's called the left anterior descending and then the left circumflex. So left anterior descending, let's find it on the picture. I think it's called something different in the picture. No, it's not. LAD, left anterior descending, and this feeds most of the left ventricle. So can you imagine if the LAD becomes occluded, which happens in a lot of people who have narrowing of their arteries because of all the plaque that's depositing in their arteries. If this becomes occluded, of all places in the heart, now you've got a left ventricle muscle that isn't getting enough oxygen. So what do you think that's going to do to your blood pressure? Yeah, so if the left ventricle muscle becomes necrotic, it can't pump blood into the aorta. So depending on how severe it is, then death ensues. So if you have an occluded LAD, it's an emergency. And I mentioned to you about going for open heart surgery and they'll bypass the vessel. Typically what they do is they'll harvest the veins from the legs and cut them and then sew them. And when they sew them, sometimes they'll sew them right to the aorta, bypass whatever is occluded, and then sew it in another spot a little bit further down. And now you're perfusing the muscle. Or the internal mammary artery, they'll clip that and then sew that past the occlusion. So that's how they bypass it. But that's in more, depending on where the blockage is, they'll determine whether it has to be that kind of surgery or can they just go for a cardiac catheterization. Cardiac catheterization, patient lays on the table and they thread a special catheter up through the aorta and stick it into the artery, either the left or right coronary artery, depending on what's blocked. And they have different procedures they can do to get the vessel opened up. One of them is just squeezing that occluded area, and that kind of opens it up. And then they put in, it looks like the spring on your ballpoint pen, and they leave this little spring in to keep the vessel open in that area. So they call that an angioplasty. So not everybody has to have their chest open and the vessels bypassed. It can be done usually with a catheter that they thread into the vessel and just force the vessel open. So LAD really important. It feeds the left ventricle, the right coronary artery. Oh wait, you have the word left circumflex. Cool. Do you know what the word circumflex means? Yeah, it goes around or wraps around. So the left circumflex artery wraps around the heart. It also supplies perfusion for the left ventricle, the left atrium, and the interventricular septum. I didn't tell you what a septum is. Do you know what a septum is? All right, so you already knew it divides the right ventricle and left ventricle, so it's a septum. So it's pretty easy if you're thinking about the left coronary artery, it feeds the left heart, the right coronary artery feeds the right heart, and there's only a few minor exceptions. It tells you that the right main coronary artery supplies blood for the right ventricle, that goes together. The right atrium, that goes together. The sinus node, did you learn about that yet in your anatomy? So the sinus node is it starts the conduction for heart contraction. All right, so that's something different that you would have to go through in your notes when you're reviewing. The sinus node is fed by the right main coronary artery. And the other exception is that it also goes by and feeds some posterior portions of the left ventricle and the septum. Can you see the right coronary artery on this picture? So the RCA is the right coronary artery. So it's feeding the right atrium, the right ventricle, but then it's also feeding some of the left ventricle. This is showing the circumflex artery. It looks a light in color here, and then it seems darker, and that's just because it's wrapping around the heart, so I guess they make it a lighter color if it's around the back of the heart. Another picture of the coronary arteries. All right, this points to the right ventricle. So what do you think this red vessel is right here? Is that it? Yes. Let's see. B is the posterior view. That's the right coronary artery feeding the right ventricle. The veins we didn't talk about. They look huge, don't they? Okay, got a couple notes I need to give you. What is collateral circulation? Collateral is spelled C-O-L-L-A-T-E-R-A-L, collateral. What is collateral circulation? All right, so to answer the question, let me explain what collateral circulation is, and then we can figure out a way that you can write it down. When vessels become occluded slowly over a long period of time, the body has a chance to build new blood vessels to feed an area that isn't being perfused by blood well enough. And so those new blood vessels that form are considered collateral circulation. So if it's happening slowly over time, there will be new blood vessels going to an area of the heart or other part of the body that isn't getting a good blood flow. So that's what collateral circulation is. So some people could have an occluded LAD, but because it happened so slowly over time, they developed new blood vessels into that area. And that's why they still have good function of their left ventricle. All right, so that's collateral circulation. What do you want to write down?
What's going to be on the test?
It will be on the test, but how do you describe what it is?
New blood vessels are formed.
Branching of new blood vessels? But why?
Because of the occluded
vessels, your body creates new vessels so it can
bypass the effusion.
Yeah. Why? Why do we want to bypass the occlusion?
to oxygenate
The tissue, yes. Okay. So new blood vessels form to provide oxygen to
Heart muscles.
under perfused areas, underperfused. If you write down underperfused, are you gonna know what that means? Like not enough blood flow, not enough oxygen getting there? Underperfused areas.
So the areas with occlusions, where you put, new blood vessels form to provide oxygen to areas that are included? So, is that it?
Areas that are underperfused. Because underperfused means you're not getting oxygen to that area. What did you write?
I wrote the creation and branching of new blood vessels to provide perfusion to areas that have become occluded over time.
The areas have become occluded?
To areas that have become occluded over time, because you said it was a process.
A slow process. Yeah, it's the blood vessels become occluded and then the muscle doesn't receive a good blood supply, an oxygen supply. Vanessa doesn't know.
No, I'll keep it short, just like how you said it the first time, when you say branching of new vessels formed to provide oxygen to underperfused areas, and just keep it simple.
Yes.
Because then I'm gonna overthink it and try to write it a long way and don't remember. You know what it is, just keep it simple.
Okay. Circle the correct answer. The heart receives its blood supply during, and you have a choice, during diastole or during systole. What do you think? You think during systole? Because that's when the rest of the body gets its blood supply. Right? So this is the exception, is the heart. The heart, because the muscle's being squeezed during systole, can't really get a good blood supply when it's being squeezed. Or not being squeezed, but when it's squeezing itself. So it gets its blood supply during diastole, when it's relaxing. And there's plenty of blood left in the aorta to perfuse those vessels during diastole. So it works out well. What are Fabrician veins? Doesn't that sound like something having to do with theatrics? Oh, that's thespian. Fabrician veins are coronary veins that drain into the, most coronary veins drain into the right atrium, but some veins drain into the left atrium. The veins that drain into the left atrium are called Fabrician veins. And they pose a problem, not really a problem, but they have deoxygenated blood. And we want oxygenated blood on the left side of the heart because that's what's going to be distributed to the body, is the oxygenated blood. So having these veins dump deoxygenated blood into the left atrium kind of goes against what we want to achieve, which is oxygenated blood.
So that's abnormal.
Well, wait, I need to tell you one more sentence. And obviously it's okay because our bodies function perfectly normal, having a little bit of that shunted blood in it. So even though we have a little bit of deoxygenated blood entering the left atrium, there's still enough oxygen in the blood to satisfy our needs. It's not really a problem. It's
everybody has, or
Yes.
or
Everybody.
something that can happen.
It's normal physiology.
Isn't it like when it goes through the pulmonary circulation, that's like the leftover? Oxygenated blood, it's like the leftover amount? I think that's how I remember something.
Leftover from,
When it goes through the pulmonary circulation and the oxygenated blood goes into the left atrium, then that leftover is the one there's some deoxygenated blood in there.
yes, so that some deoxygenated blood came from the Fabrician veins. So having this deoxygenated blood go into the left atrium, it's considered shunted blood, and it gives you the definition. It says any blood draining into the left heart that has not picked up oxygen from the lungs is considered shunted blood. And we go into a lot more detail on shunted blood, but later on in the semester, just so you have a basic understanding now. So shunted blood is blood that did not pick up oxygen and it ends up in the left atrium. What is Frank Starling's law? And it tells you. It says the more the cardiac muscle stretches, the greater the contractile force during the next contraction. So this kind of answers a question of how does the heart accept 200 mLs of blood and know to get rid of 200 mLs? What if it only accepts 50 mLs? How does it know to contract just to get rid of that 50 mLs? And the answer is in the stretch. So if there is a lot of blood in the ventricle, it stretches the ventricle more. And then when the ventricle contracts, it contracts more forcefully. So a lot of stretch, more forceful contraction. Little stretch, less of a force when it contracts. There's a question in, I think it's in the workbook, and it asks, does the left ventricle and the right ventricle eject the same amount of blood when it contracts?
No.
What do you think? You say no? Which one?
The left ventricle, the left on the bottom ventricle, I think, is the one that ejects more.
You think it ejects more than the right? And then, so when the heart contracts, more comes out of the left than comes out of the right? You think so? Does everybody say? You say the same?
Yeah.
Because it's better.
The blood comes
When it comes in, goes
and
out.
then it's oxygenated, then it
Yeah.
goes out, so that's the same.
Yeah.
Yeah, can you imagine if it's not the same, if you do have a lot more and you don't have very much leaving the right? So in order for the circuit to work correctly, it needs to be the same amount of blood. Now, when you start exercising, that causes more blood to come back to the right atrium, but within a few heartbeats, it evens out again. So, yeah, if you come across that question. Characteristics of cardiac cells. Just some definitions. The automaticity, it says the cardiac cells can originate an electrical impulse. This is just getting you ready for EKG class that you'll have in the spring. What I have written down, it says any cell in the heart has the ability to initiate an impulse and to contract, which kind of explains, I'll read it again for you in a second, but it's just kind of explaining how we can have irritable areas in the heart, and if you do have an area of the heart that's not getting enough oxygen and it becomes irritable, it starts its own conduction and starts sending out impulses into the heart, and we end up with cardiac arrhythmias. So that's the reason for me giving you the definition. All right, so I have any cell in the heart has the ability to initiate an impulse and to contract. I'll say it again. Any cell in the heart has the ability to initiate an impulse and to contract. So that's automaticity. And it kind of explains how heart arrhythmias can occur. Excitability is that cardiac cells respond to an impulse. Conductivity, cardiac cells can transmit an electrical impulse. And contractility, cardiac cells can contract. Not a whole lot to say about those. But it leads us into cardiac conduction. And just to look at the picture first, and then I'll give you some notes to write. There are special nerve cells in the heart, and these nerve cells travel along the heart muscle, and they stimulate the heart muscle, and then the heart muscle can contract. So these special nerve cells are just called the cardiac conduction cells, but they're special nerve cells. We start off with the SA node. This is the normal pacemaker of the heart. The normal pacemaker of the heart. Do you know what SA stands for? SA. Sinoatrial. SA stands for sinoatrial. So SA node, sinoatrial node. All right, so the SA node will initiate an impulse, and then it's going to spread to the rest of the heart. That's where it starts, is in the SA node. When it leaves the SA node, impulse travels through both atria. Can you repeat that? Impulse travels through both atria. Impulse travels through both atria and then to the and the next thing is the AV node. And a picture of the SA node and the AV node. So the SA node is buried up on the top of the right atrium. And then you can see how you've got conduction going to the left atrium, but you also have conduction going down the atrium and ending at the AV node. And AV, what do you think that stands for? Excellent. Atrioventricular, AV node. So that's where the impulse heads to next. So it gets to the AV node, the impulse pauses here, and then I need to explain why the impulse pauses at the AV node. It gives the atrium time to contract.
So it pauses at the AV node to give the atria time to contract.
Perfect, yes. And so we talked about the atria being collecting chambers and it's collecting blood. And at the same time, those AV valves are open. So as blood is flowing into the right atrium, it's dripping down into the right ventricle too. And at the very end though, the atria contract and that forces a little bit more blood into the right ventricle. Same thing's happening on both sides. So in order for the atria to have some time to contract, that conduction needs to pause for a little bit. Let the atrium contract, and now we can continue on. All right, next thing you have is the bundle of His. The conduction tissue penetrates. This conduction tissue penetrates the thick AV septum. You have a lot to write for this slide. penetrates the thick AV septum, and there's more. It relays the impulse to the right and left bundle branches. It then relays the impulse to the right and left bundle branches.
So the bundle up here is the conduction tissue.
That penetrates the AV septum. All right, so we need a picture of the bundle of this. So the AV node, it received an impulse, pauses a little bit, and then it sends the impulse the rest of the way. So the next place it goes is through the bundle of His. This nerve tissue goes through that real thick AV septum, and then it spreads to the right and left bundle branches. So you have all that? All right, the next on your notes, it talks about Purkinje fibers. Do you see these little fibers branching off of the right and left bundle branches? Little fibers that go into the ventricle muscle? Those are the Purkinje fibers. So what I have is they innervate the ventricular muscle.
Say that again?
Purkinje fibers innervate the ventricular muscle.
It would be on both sides, right?
Yes, yes, right and left. Yeah, this is a cutaway view, so it's showing how the right bundle branch is spreading to the right ventricle, and then you've got the little Purkinje fibers branching off. Then the left bundle branch spreads to the left ventricle, and then you've got the Purkinje fibers branching off. So yes, both sides. All right, so that's the conduction system. SA node sends an impulse to both atria and the AV node. And you get a little pause in the conduction, and after that, conduction goes through the bundle of His. It separates into the right bundle branch and left bundle branch. And from there, it goes to the Purkinje fibers.
That's where the impulse is for the heart to contract, right?
Yes. So that has to happen before the heart can contract. So first you have to stimulate all the muscle cells, and once they're all stimulated, then they contract. So when you're looking at an EKG, you're looking at the cardiac conduction. You're not looking at the heart contracting, you're just looking at the conduction of the nerve tissue. And then just a little bit of information about how an EKG comes about. And it all has to do with ions moving back and forth across the cells in the heart. And just ions moving back and forth can actually change the electrical charge. And when we look at an EKG, that's all we're looking at, is just a change in electrical charge in the heart. So where does that come from? It just comes from sodium, potassium, and calcium moving back and forth across the membrane. Isn't that amazing? So it tells you that cardiac muscle fibers keep high concentrations of positive ions just outside their membranes and high concentrations of negative ions just inside the membrane. This electrical charge is called the membrane potential, or you're here referred to as action potential. It's just an electrical charge that can change. So when the cell is resting, if you could get a little voltmeter and stick it inside of the cell, you would measure a negative charge inside the cell of minus 90 millivolts, and then 0 on the outside. I guess 0 is considered more positive than minus 90. Okay. Name the ions involved in maintaining the action potential. It's blank, blank, and blank.
Potassium, sodium, calcium.
Yes. Okay. Sodium, what is that abbreviated as? Na. Potassium, what is that abbreviated as? K. And calcium, Ca. So you got that? It says it is the movement of these ions back and forth across the cell membrane that creates the change in electrical charge. Before a muscle cell can contract, the inside of the cell has to become positively charged. So in order for it to contract, it's got to be positive inside the cell. So that's when all the ions move in and make it positive. This slide is kind of repeating the same thing again. It asks, what causes the cardiac muscle cells to become positively charged so they can contract? But you already know the answer to that, right? It's the movement of ions. It says the electrical impulse originates from the SA node, the sinoatrial node, and spreads throughout the conduction system. This electrical stimulus causes the cardiac muscle cells to, and then it leaves a blank, and you're going to write the word in depolarize. So when the inside becomes positive, it's called depolarize. D-E-P-O-L-A-R-I-Z-E. And then the next bullet, depolarization occurs when the minus 90 millivolt charge inside the cell becomes positive. So the cell becomes positive and then it can contract. And then you have another blank to fill in. Blank occurs when the minus 90 millivolts are reestablished. Yes, very good. Repolarization. So if I were to ask you to explain to me how it happens where cardiac muscle cells contract, you'd have to tell me about first the conduction system and how the conduction system stimulates all the muscle cells. Then you would tell me, well, once those muscle cells are stimulated, the inside of the cell becomes positive. And it does that with the movement of ions. Once the inside of the cell is positive, then the muscle can contract. So that's how you would explain it to me. Does that make sense? All right, and then depolarization and repolarization of cardiac muscle can be detected by an electrocardiogram. And we call it EKG. It's supposed to be ECG. I guess an electrocardiogram started out as a German word, and it was spelled with a K. So in English, we spell it with a C, but we still say EKG. Sometimes you'll hear ECG at the hospital, most of the time EKG. All right, and then there's different waves on an EKG. There's a P wave, a QRS, a T wave, and a PR interval. I'll give you some notes on this and then we're going to stop. Before I give you the notes, let me show you the picture. So looking at an EKG, every time right before the heart contracts, you're going to see these waves on an EKG. After you see this, then the heart contracts. We don't see the heart contracting, all we see is the cardiac conduction. So when the atria depolarize, we see a P wave. When we see the QRS wave, that's the ventricles depolarizing. When we see a T wave, that's when the ventricles repolarize. So you already started writing? Oh, okay. All right, P wave, what did you write? Okay, so when the atria depolarize. QRS? Okay. Ventricular depolarization, or you can put ventricles depolarize. The T wave? Ventricles repolarize. All right, so we talk about the ventricle depolarizing, the ventricle repolarizing. What about the atrium? What's missing from the atrium? Repolarizing. And the reason why, so the atria depolarize. When they repolarize, we don't see it because it's kind of hidden behind the QRS. So the atria do repolarize, but we just don't see it. So there's no waveform that you could point to and say, oh, look, the atria are repolarizing. The only thing you see is when they depolarize.
And that's the PR interval?
No, just the P wave. When the atria depolarize, that's just the P wave.
Where does it repolarize the QRS? You just don't see it?
It's hidden by the QRS. Now the ventricles are a much larger muscle mass, so when they depolarize, you get a big QRS. When the atria depolarize, they're smaller, less muscle mass, so you just get this little blip. So big ventricles, little atria. All right, and then the next thing you need to write for your notes is what the PR interval is. It shows you on this picture. The PR interval just means time, amount of time. From the atria depolarizing to when the ventricles depolarize. So the PR interval is the time it takes let's see what I have. The time it takes for an impulse to travel from the SA node to the ventricles. I'll repeat it.
Excuse me, thank you.
It's the time it takes for an impulse to travel from the SA node to the ventricles.
What did you say earlier about from atria depolarizing to the ventricle?
To the ventricles depolarizing.
That's the same as PR, isn't here?
Yes. Yeah, so PR interval, it's the time it takes from the SA node to the ventricles, or you could say from the atria to the ventricles to depolarize. All right, so showing you this EKG tracing, this is over a period of time. So it's a matter of seconds. And for the heart to completely depolarize, it takes 0.3 seconds. So we're looking at 0.3 seconds of time here. And from the beginning of the P to the end of the T is 0.5 seconds for everything to be back into normal. So for them to depolarize and repolarize, 0.5 seconds.
0.3 to depolarize?
Yes, for the ventricles, the atria and the ventricles to depolarize, 0.3 2 seconds. For everything to be complete, to be repolarized, 0.5 seconds.
Full cycle.
Full cycle, 0.5 seconds.
So 3 seconds to depolarize and 0.5 to repolarize.
So depolarize is when the cells become positive inside, and repolarize when they become negative, negative 90, right?
Yes, excellent. Good job. So we have interval, and that's all for today.
So the rest of it will be on the exam.
Just what we covered, and that's it. So you can write in your notes, exam up to here. No, I want to talk about the test next Tuesday. Oh, we have no internet service? Oh, that's not anything. No kidding. All right, I can tell you. When you go into D2L, it gives you some test-taking tips about next Tuesday. When you come in for the exam next Tuesday, I'll give you a Scantron, so you don't have to provide the Scantron. And you have about 2 minutes per question, so there's about 35 questions, so you'll have about 70 minutes to complete the exam. If you come in late, you don't get any extra time. It's still, when the exam is finished, you turn your exam in. So I really stress how important it is to be on time. I don't like exams to be stressful, but unfortunately they are. And I understand that. But when you're trying to focus on the test and then you've got the door opening and slamming and people are talking and they're shuffling into their seats, it's hard to focus and work on the test. So it's really important to your classmates that you're all here on time.